Have the pleasure of introducing Dr. Andrew Callen for the third time, I believe, this morning, which is a reflection of the great work that's being done by him. Without further ado, Dr. Callen.
All right, let's talk about fibrin glue. I'm going to talk about fibrin glue, but I'm also just going to talk about patching in general and my experience with it and sort of techniques and sort of tricks that we've learned. All right, so here are my disclosures again. So we're going to first talk about, what is fibrin glue? Is it glue, like Elmer's glue? What exactly are we dealing with here? Risks and special considerations when using this product in our patching procedures. And then, again, we're going to march through each leak type and talk about how I think about fibrin glue as applicable or not when treating them. So what is fibrin glue? Well, it's a biological sealant. It's not a synthetic material, it's a biosynthetic material. And it's really two things. It's derived from recombinant components of human blood. It's fibrinogen and it's thrombin. And it's in sort of a dual syringe that we inject, and those two components combine and sort of form this clot. And what we think it's doing is replicating the last step in the coagulation cascade and polymerizing into this 3D fibrin mesh that will eventually be resorbed by the body. And we're hoping that it's providing this watertight hemostatic seal. It's used frequently in surgery for this reason, and it's sort of a scaffold for dural healing in the context of a spinal CSF leak. It's important to remember and to consent our patients that this is an off-label use of this, both in the United States and from my best 5-second Google search also in Canada. This is off-label use, so we make sure that they understand that. What is the evidence for using fibrin glue in patching? It's actually not that strong. Dr. Shiving back in 2004 described a 4-patient case series where they used fibrin and it was safe and effective for treating a CSF leak. And I think a lot of us, that was the jumping off point for realizing that this was a useful tool. There was this nice study done where they looked at postpartum women with refractory post-dural puncture headache, and they were randomized to blood or fibrin patches. And those patients who received fibrin patches did better. They had higher patient satisfaction, they had a shorter hospital stay. So this is, I think, one of the better studies, stronger studies supporting its use, but really we need to do more work to understand when is it good to use and when, how much better is it than blood. There's different types and brands of fibrin, but I'll just cover 3 types that I think are more commonly used. I think these Baxter products, the Tisiel and the Artis, are most commonly used. These are the ones that I use. The Tisiel has a higher thrombin concentration, and you can see they all come in those dual syringes there. And that higher thrombin concentration results in a shorter working time. So when you're injecting this, it starts sort of hardening pretty quickly, and you have to make sure that you're in the right spot because very soon your needle will be gummed up with that glue and you'll be done. It also has this aprotein in it, which is important when we talk about allergic reactions, we'll talk about in a second. Baxter also makes a product called Artis, which has a lower thrombin concentration, and because of that, you have a higher working time. It's a little bit less viscous, and it takes a little bit longer to set in. And I'll talk to you about when I like using the Artis versus the Tisiel. And then Vistaseal is another option that is kind of more similar to Tisiel, I think, but that aprotein is absent, which may decrease the chance of a hypersensitivity reaction, which could be important. This was mentioned before, but we had one of our residents, Dr. Montez, did this study looking at all of our patches and seeing how they moved in the spine depending on where we placed them, the volume, the composition of them. And I think that a lot of the points of this was covered already, but I think that one of the more interesting things that's relevant for this talk is that we think about fibrin having these distinct rheological properties of this high elasticity and deformability with its low protein density. And because of that, we saw that the fibrin, when injected by itself, had a higher spread to volume ratio, meaning normalizing for the amount that you're injecting, it's going to spread more in the spine than blood alone. But when you mix fibrin with blood, it actually spread less compared to fibrin alone. So there's something that happens when the fibrin is mixed with the blood where, we can think about it conceptually as, it's a super patch, some sort of synergy between these two. It is spreading less. It is perhaps a stronger patch. I'm not sure, but it's interesting to think about how mixing it with blood changes that. talking about the specific risks of fibrin. So, if you work with this, you realize that there's this chance of a hypersensitivity reaction. Luckily, Duke put out this study recently with a lot of patches, very well powered. They looked at over 3,000 patches and basically found that the risk of a hypersensitivity reaction, of allergic type reaction, was about 0.5% per procedure. And on the first exposure, it was 0%, right? So you had to be exposed to this in some way. So we're asking our patients, have you ever had a fibrin patch before? Have you ever had any sort of surgery before where you could have been exposed to fibrin? And it was interesting. It was a higher risk in younger patients with a lower BMI and a higher risk with intravascular spread. Right? So when you see the glue go into a vein, that was a higher risk as well. So, we want to pre-medicate these patients with Benadryl. We give them 50 milligrams 30 minutes prior to the procedure. Of course, 50 milligrams of Benadryl is not going to stop anaphylaxis from happening, but it might buy us a little more time or sort of dull things a bit. And then again, that aprotein we think is the trigger for these reactions. So using a product like VistaSeal that doesn't have that in it could be useful in that regard. Thromboembolism, right? We're creating this big clot. We're injecting in a highly vascular space. Could this be a problem? We did a multi-institution study looking at fibrin patching for CSF venous fistulas. We looked at 119 of those. There was 2 incidental pulmonary embolisms in those, but both were clinically silent. So the patient was not, both times the patient was admitted because we were really worried, but the patient's O2 sat never dropped, they never had chest pain, and if it wasn't for the fact that we saw it on the image, it wouldn't have been a problem. And then there was intravascular fibrin actually in 31% of those injections, but there was no symptomatic thromboembolic events in our study. So, it's important to tell the patient that there is this risk that we're putting this clot in, it could go into a vein, and that's bad. But then again, how clinically relevant is that is maybe less certain. You want to do a test injection, of course, with contrast before you inject your patch material to know where it's going to go. Are you in a highly vascular structure? You don't want to be intra-arterial into a radiculomedullary artery of the spinal cord, for example. I like to, if I'm even wondering if that could be a possibility, inject a little bit of lidocaine first and assess the patient before I give my patch to see whether or not there's a possibility of being intra-arterial. Patients ask me all the time, they're very worried about arachnoiditis, and the sort of evidence behind fibrin in and of itself causing arachnoiditis is actually pretty weak. There's 2 case reports that I could find that described arachnoiditis after epidural injection of fibrin. And there's 3 multi-center patching studies, ours looking at 119 patients with CSF venous fistulas. There was no cases of arachnoiditis there. 56 lateral leak patients in a study that we have ongoing. I'm going to present some of that preliminary data today. There was no cases of arachnoiditis there. And then 52 ventral leak patients with glue, and there was 1 case of suspected arachnoiditis, and that patient was put on a steroid taper, and that resolved. So, this is a risk, but the true risk is probably likely low. When I talk to my neurosurgeon, Dr. Leonardson, he thinks that it's probably lower than blood alone as an injectate. So let's go through each of these sort of leak types and how I think about using fibrin in each of them, starting with ventral leaks here. So you can see a very long needle here being threaded into the ventral epidural space, and then you could see this surgical defect there. Now, I talked about this in an earlier lecture, but this is important to think about in the context of ventral tears. So remember, on the acute presentation, the epidural fluid collection is going to be unorganized. It is going to be spreading in the dorsal epidural space, egressing out of the neural foramina, and then in the chronic state, these will become organized. They will become these very well demarcated, convex, shouldered edges. And what we were very interested in is does this leak type, this sort of organized leak type, respond differently to patching than not? And what we think is, and from the intraoperative experience, is that often these leaks are, when they're visualized, they're covered by this highly vascularized thick membrane. And you can see here in this nice photo when the membrane's been partially dissected, that and the dura is beneath it. And we wondered if that organization feature of the fluid collection was actually reflecting this membrane formation. And perhaps could these membranes actually be blocking our patch from getting to the leak site? Is this why some patients aren't getting better when we're trying to patch them? And I think that you can look at when you patch somebody with an unorganized fluid collection compared to an organized one and see distinct differences in how the patch is spreading. So this patient has an unorganized fluid collection in the acute setting, and I just did a dorsal epidural patch, and you can see that my patch, which is mixed with contrast material, is spreading circumferentially throughout the epidural space, coating the ventral epidural space very, very nicely there. But when the epidural collection is organized, the patch is not getting into that organized SLEC. So look here, there's this organized collection ventrally. I flipped the MRI to sort of match my patch image, and shown by the yellow arrows there. And I'm injecting that dorsal interlaminar, and my patch is just stopping right where that organized collection is. And so this is why we started thinking to ourselves, maybe we need to get our needle into the area of that organized collection. We can't just come posterior. We can't just go a typical transforaminal injection, but rather have to get into that collection itself. And so what we started doing is actually getting a very long needle and threading it into that organized collection. So we place the needle into that collection. We'll do a little air test here, and you can see on that air test, you see that air outlining that organized epidural collection very nicely there. And then we inject our patch material. I like using the Artis product for this because I have longer working time. I will inject some blood, some Artis, some blood, Artis, kind of incrementally like this, and try to fill that organized SLEC with my patch material. And even if I'm not over the direct leak site exactly, then it will spread up to the leak site, hopefully. And these needle placements can be very challenging, and you have to use very long needles sometimes, like in this patient here, sometimes kind of riding right along the scapula to get into that ventral epidural space, as shown here. Sometimes you have to not just take a far lateral approach to do this, but you have to reposition the patient. This patient, when I got him on the table, I couldn't find a way to get into the ventral SLEC as much as I wanted to, so I basically had him hug himself with one arm, and that moved the scapula out of the way. That allowed me to get the needle into that ventral collection. Sometimes when you put your needle in this space, you have to be careful, not just with your ear test, but with a little bit of contrast to make sure you're not too intravascular. This was a very interesting one because my contrast was getting into the SLEC, but it was also draining robustly into the internal and external epidural venous plexus. And I didn't want to patch this because it felt like there was way too much vascular uptake. But you wonder in some of these patients, is some of the pathophysiology here actually the SLEC being resorbed by this robust vascular uptake in combination with these vascularized membranes that occur? But yeah, those are cool pictures of long needles going into the spine from crazy angles, but is it actually helpful for our patients, right? So we looked at, in patients who received a targeted patch, meaning just a normal patch, dorsal interlaminar, transforaminal, versus an intra-SLEC patch, when they had that organized collection, it turns out that we fix them a lot more if we get the needle into the SLEC. 33% of those patients we could get SLEC resolution, compared to 4% if they just had a dorsal interlaminar or transforaminal patch, once that SLEC was organized. And then, the rate of resolution in an unorganized collection with a targeted patch was only 54% in our cohort. That's actually pretty modest, pretty poor. Now you wondered, this was us and Kaiser, both tertiary referral centers for leaks. These were probably more complex cases that had received other patches before, but still not as good as we might like to think, that we just perform these patches and send the patients home and call it a win. So for ventral leaks, remember, getting into the SLEC, if the SLEC is chronic, can help. I like to use blood and glue. I like to use Artis. I don't have evidence behind that. It's just my personal opinion. And I like to go very, very slow here. The patient is awake, often with moderate sedation, but I'm asking them about their symptoms, both localized pain, radicular or myelopathic pain, and then also any sort of high pressure symptoms. They start telling me my ears feel like they're popping, or I'm having pressure in my head, we stop. Let's talk about lateral leaks now. So here's just 3 examples of some lateral dural tears. Here's an example, just a case example, a 34-year-old woman. She was doing a Peloton class, and she kind of got up on the bike and all of a sudden developed a headache, really trivial trauma. She has obvious features of intracranial hypotension on her brain MRI, has this fluid collection. She received 2 prior non-targeted epidural blood patches before coming to us, and we just did a fibrin patch right where we found her leak to be, which is a T11-12 level, no blood combined with this, and it was just 4 cc's of Artis, and this resolved her symptoms very nicely. So this was a very useful thing. But I want to talk to you a little bit about this preliminary data that we've done with 5 other centers across the United States, Germany, and the UK about patching these lateral leaks. And what we found is that it doesn't matter whether you use blood or fibrin, how much you inject, whether you put your needle transforaminal or dorsal, The only thing that we found that affected whether or not patches resolved a SLEC was whether or not there was a visible herniated arachnoid pouch on a spine MRI. If you see this finding on a spine MRI, it was much less likely that we were going to resolve this patient's leak with a patch. And you could think about, it maybe makes sense mechanically that there's this large herniated arachnoid pouch sort of propping the dura open. We're never going to be able to reduce that with a patch. That needs to be surgically repaired. But when you don't see an obvious pouch, it doesn't mean there isn't one there. Almost always there's intraoperatively, they see these coming through, but if you don't see it obviously on the spine MRI, like in this case, there's a greater chance of success. So this patient had an epidural fluid collection, had a lateral dural tear here, and we just did our fibrin patch right transforaminally at the level of the leak, and he had resolution of his fluid collection and symptoms as well. So this is a very good application for patching, not that you shouldn't try, but just in terms of counseling the patient and the potential risk for surgery. So again, for lateral leaks, there's a modest efficacy, but it is safe. We had complete symptom relief in 36% of patients and SLEC resolution in 25% of patients. In those 56 patients, there was no procedural complications. That visible herniated arachnoid pouch is key in terms of the success or failure of the patch. No other variable really made any difference at all in terms of us fixing these leaks. And I think this is one of the most interesting things about this disease in general and something that we need to understand better. But there was discordance, there was clinical radiologic discordance in both directions for these patients. We had 45% of patients who felt 100% better, but they still had a SLEC on their spine MRI. And we had 48% that had radiologic cure. Their SLEC was gone, but they were still symptomatic. And I think this is one of the most interesting parts of this disease, that we are missing something in these patients where even though the imaging may look better, they are still not feeling better. So now I want to move on to CSF venous fistulas in terms of the application of fibrin in this case. Here's a very large CSF venous fistula that I like showing just because it's humongous. So there's three sort of mainstays for treatment of CSF venous fistulas. We have fibrin occlusion or patching, onyx embolization, and then surgical ligation. And you could think about them in terms of efficacy and invasiveness. For fibrin occlusion, I like this because I can look for the patient's fistula on the scanner, and then I find it, and then I turn them from lateral decubitus to prone, and I treat them right there. We did a multi-site study on this, and we found that cure rate, and I'm defining that as both the patient's MRI brain findings resolved, but the patient themselves is saying, I am asymptomatic, was 59% on an average of just under 3 attempts of fibrin per patient. But needle placement was incredibly important. I'm going to talk to you about that in a second. It's why I don't even really like using the word patching when I'm talking about fistulas, but I say occlusion. Onyx embolization, incredibly exciting, very promising procedure, a very high cure rate. There's less multi-site data. The biggest sort of series of this came out of the Mayo Clinic. They had 100 patients, and what's interesting is, if you read the abstract, it's not evidently clear, but if you look deeper in the results for patients reporting complete symptomatic resolution, it was 58%. So actually very similar to fibrin in that regard. And then surgical ligation. So this is a very, very high cure rate, but it may require nerve root ligation or clipping. That's not a problem in the thoracic spine when the nerve roots are non-eloquent, but if you're cervical or lumbar, that can be an issue, and where these less invasive techniques can come into play. So this is one of the main points I want to drive home if you're thinking about using fibrin for treating leaks. If you are an interventionalist who is taught to do transforaminal injections, you are not going to be placing the needle in the same way that you would normally for a steroid injection, a nerve block, what have you. That solid line there is showing, what I would do if I was just trying to do a transforaminal injection. I would try to get my spread along the sort of nerve root complex, and when I was in training, if we're doing a steroid injection or something there, and someone into the dorsal epidural space, my attending pats me on the back and says, oh, you gave him a free epidural too, that's great, that's fantastic. But that's not useful for fibrin. So what we actually want to do is build a wall of glue along the draining pathway of the fibrin itself. And so we're going to take a different needle trajectory, placing it at the origin of the fistula itself, not necessarily just a conventional transforaminal approach. And what we found is that when our glue spread, that after injection matched the drainage pattern of the fistula, we had a much higher chance of curing the patient. So you can see here, we call this a concordant spread, where the fistula drainage pattern is really matching where my glue is going, compared to a discordant spread, where the glue is really sort of foraminal and sort of dorsolateral epidural, but the fistula is arising probably from the anterior aspect of the proximal nerve root sleeve and draining to the paraspinal segmental vein. That glue isn't doing anything, maybe exerting a little mass effect there. So I think it intuitively makes some sense. So let's talk about where to place the needle. This is the same patient I showed earlier with the fistula that drained up into the level above. So I think that it's useful, again, to look at your multi-phase imaging, being very sure where the nidus is. We see that nidus coming at that T7-8 level there, and then draining up. and above, into the level above. And so I don't want to necessarily place my, my needle into the distal part of the draining vein. I want to put it right where the origin of that fistula is. And so I'm going to be placing my needle right there, right at that origin where I saw it on that first image. There's my needle tip touching that origin, and we got spread along the course of the vein and actually into the vein itself. And this patient did quite well. So for fibrin, the key points here is, I like to use Tisiel. Remember, you're not just doing a typical transforaminal injection here. You want to put the needle at the nidus of the fistula. After you inject, look at your glue spread and say, is this going over the course of the fistula drainage pattern, or is this just going into the epidural space, and in case you might want to do a second injection? And yeah, so in conclusion, for fibrin, this is a tool that can treat all leak types, really, and it's either in combination with blood or alone for a fistula. It's really important to understand the specific risks about this. We don't have really a ton of data on it, but we do have good data now, I think, on hypersensitivity reactions, thanks to the Duke group. And then each leak type has its own special considerations, right? So for a chronic ventral leak, think about putting that needle inside the SLEC itself. I think you really do need to have CT guidance for that. For lateral leaks, remember, the presence of that herniated arachnoid pouch is going to really dictate success. And using fibrin is a good idea, but really we, in our study, did not have evidence that using it was any better than blood necessarily. And then for fistulas, not a typical transforaminal injection, putting it at the origin of the fistula is going to give you a higher chance of success. Thank you.